Hello, everybody. This is Dr. Albert Heuer. I am a professor at Rutgers University. I am a co-editor of several textbooks, including Egan's Fundamentals of Respiratory Care. I also co-edit the Comprehensive Respiratory Therapy Exam Preparation Guide. But I'm coming to you today as the co-owner of A&T Lectures. I've prepared this presentation as a practical endpoint to some of the pulmonary function testing topics that we've presented on. This particular lecture is focused on reviewing strategies for doing well on the RPFT and CPFT exam, and more particularly to focus on questions, answers, and explanations that are similar to the questions that you can encounter on those credentialing exams. We want to thank you for joining us today, and we hope you get a lot out of this lecture. Before moving on to the more substantive portions of the presentation, I feel an obligation to basically release this disclaimer. So I am an item writer for the MBRC, and in fact, I've written questions or items, as they're called, for the RPFT exam. However, I have not used any of that material, which is restricted by the MBRC, to prepare this presentation. More specifically, the information presented from the MBRC is publicly available, and the questions included in this presentation are similar to, but they're not actual questions used in these credentialing exams. So regarding learning objectives, to kind of frame the presentation itself, the primary learning objectives include examining the rationale for pursuing these specialty exams. So if there's any nurses that are in the audience or listening to this presentation, respiratory therapists have primary credentials that are needed to enter the profession. Those are the TMC, or the multiple choice exam, and the clinical simulation exam. Now, to tip my hand a little bit, in the future, the clinical simulation exam portion will be going away. That's not going to happen for a few years, but around 2027 or 2028, it will be one single exam with two separate cut scores. One, the lower cut score for the CRT, or Certified Respiratory Therapist, and the other, the higher cut score, would be for the Registered Respiratory Therapist. Those credentials are needed to gain licensure from the 49 out of 50 states that have licensure for respiratory therapists. However, there's additional exams, specialty or supplemental exams. And without going into what all of the others are, the ones related to pulmonary function testing are the CPFT, the Certified Pulmonary Function Technologist, and the RPFT, the Registered Pulmonary Function Technologist exam. This presentation is focused on, basically optimizing or enhancing the chances of candidates for these exams doing well and actually attaining these particular specialty credentials. The review will also include key resources available from the MBRC. So while I'll be sharing some questions with you, as I said, we'll also be, directing you to the MBRC's website and some of the tools and resources that are available from that organization. We'll examine sample questions, not just the questions, and it's not just the answers, but also explanations as to why the correct answer is correct and why the incorrect answers are not correct. We'll describe how to prepare for the exams, and I say exam or exams, the CPFT and the RPFT. We'll review some test taking strategies, and we'll provide you with some key resources. Now, I have a confession, and the confession that I have goes like this. Although I achieved the C in RPFT a very, very long time ago, so I don't need to re-credential every 5 years for those exams. In fact, when I took those exams, they literally were sit-down exams where you actually had a book that you had to answer the questions in and things along those lines. So my confession goes like this. About 3.5, almost 4 years ago, I took the ACCS specialty credential exam. So that's the Adult Critical Care Specialty exam. And that was the first credentialing exam that I had taken in a number of years. And unlike the ones I had taken in the past, this was done at a test center. It was done by a computerized methodology, very closely controlled. You couldn't have your cell phone. There's a lot of do's and don'ts and that sort of thing. All right, and it was a bit of an eye-opener for me. But what I had done was, in preparation for taking the ACCS exam in that manner, I made sure that I went to the NBRC's website, that they have some templates that emulate the screen that you'll see for each of the questions and things along those lines. They tell you how to save a question. I'll talk more about that. But again, we'll be focusing this presentation mainly on content, questions, answers, and explanations, but also sharing some test-taking strategies and, again, some of those resources that are available from the NBRC. So one of the questions that I ask my respiratory students is, how did you get here? How did you become interested in respiratory care? And then I also do some teaching for individuals that, such as, what Terry and I are doing in these continuing education webinars and that sort of thing. So we do also do some education and training for folks that already have these credentials. So, we ask, whether it's students who are learning to gain entry into the profession, or it's individuals, perhaps such as yourself, who are seeking these specialty credentials from the NBRC. Why bother? Okay, why bother? And I'm a big proponent. I love teaching. I love learning. Makes me actually a better teacher too. And by the way, in preparing these presentations, not just this one today, but in preparing a lot of these presentations, I myself learn a lot in that process as well. So knowledge empowers people. It doesn't make you more powerful than the people around you, but it empowers you. Knowledge is a beautiful thing. It enables you to, when you look at test results, to better position yourself to contribute to the discussion as what's wrong with the patient. It empowers you as an individual because people look at you differently when you have these answers. It empowers you as a respiratory therapist. It's good for the profession when respiratory therapists have some of the answers and can productively contribute to the patient assessment and designing and implementing the care plan. So knowledge can be obtained from education and credentials. The CPFT and the RPFT are just two such examples or of credentials which can help empower you. Your career opportunities can be expanded, and the respect you garner from your peers enhanced. So this is a screenshot, if you will, from, it's not the landing page for the NBRC, but when you click on RPFT, this would be what you'd see. Okay, so it says RPFT, the green, if you want to call it a button, or the green panel that you can click on is how to apply for it. Beneath that are a series of 7, if you will, buttons, resource buttons that talk to scoring, admission requirements. They have a free practice exam which you can take multiple times. They talk about general exam information, exam frequently asked questions, and there's also discount vouchers that are available from the NBRC as well. So I just encourage you, even if you're remotely considering taking the C or the RPFT exam, I would spend some time poking around at their website, and in particular, these resources that relate to pulmonary function testing that they have available. And as you click further down from the NBRC, you will have what's called the exam matrix. The exam matrix. Now, this isn't the entire exam matrix. This is an excerpt. Again, publicly available. It is copywritten rather from the NBRC, but they encourage sharing it in manners such as this. And the beautiful thing about the exam matrix is it's like an outline if you think of. So it's the, the first section there is instrumentation and equipment. So it's Roman numeral 1. Then you have A, how to set up, maintain, and calibrate. And then you have 1, in this case, through 18. But it continues on and on. And what it does is the matrix tells you the number of questions and what cognitive level those questions are at. So you have 3 cognitive levels. You have recall. Recall is, what's the normal, if you will, FEV1 for, an adult male, 65, whatever. It's a recall. It may be a range. It may not be an absolute number. An application is then applying that. Okay, applying that. How would it's not just a recall, but is it normal? Is it not normal? And what are some of the things that could cause it to be so? The analysis is taking it a step further to critical thinking. Okay, so if it's abnormal, what are some of the conditions that could contribute to it, and perhaps what are some of the treatment modalities, or what are some of the care plan elements that would be recommended as a result of that. So it gives you the number of questions, the breakdown. It gives you the overall, category, the secondary category, and then the more discrete tertiary category where it talks about things like calibration and troubleshooting and things along those lines. Strongly encourage you, if you're considering these exams, to actually print out a copy or take pictures via your phone and spend some time saying to yourself, well, I know a fair amount about this. Oh, this other section I don't know too much about. I need to spend more time reviewing that so I can enhance my chances of doing well on the exam. The other thing I'll say about the exam matrix or outline is, again, it's really important to kind of identify not just areas that you might find more difficult, but in general areas that tend to be more challenging. And I have a short list here. It's not intended to be an all-encompassing list, but it's a few of the categories that exam candidates tend not to do quite as well on. So interpreting the results, that's something that the more results that you interpret, the better you can become at it. Parameters for acceptable results. Okay, really important. There'll be questions on that. ATS, or American Thoracic Society, parameters for test acceptability. And then doing things like quality control on the equipment. So some of this stuff, not the interpretation, but some of the what's an acceptable result and the quality control elements that you need to be mindful of may not be jazzy, may not be exciting, if you will. But if you're going to work in the pulmonary function testing lab, or you think you might down the road, these are things that you're going to need to know. You're going to need to know what constitutes an acceptable result. You're going to need to know when the equipment needs to be calibrated, how it's done, what's acceptable, things along those lines. So while, again, this stuff may be a little more on the boring side of the spectrum, it's information that you're going to need to know both for the exam and if you ever end up working in that sort of an environment where pulmonary function tests are being done. Now let's spend some time looking at questions. These are questions, again, that are similar to, but not precisely what would be on the exam itself. And I've started you off with a few questions that are on the easier side of the spectrum. So question 1, a patient has a peak expiratory flow rate of 5.2 liters per second before bronchodilator treatment and 6.3 liters per second after it. What percent change in peak flow has occurred? Let's take a look. The choices: A is 8%, B is 17%, C is 21%, and D is 26%. And note that the NBRC, for the most part, has spread the answers over a pretty decent spectrum. In other words, they don't have, A is in 17, B is in 18, C is in 19. They've kind of spread them out. And that's really to guard against if you did like a rounding, and not even an error, you just rounded a particular way, you did everything else correctly, you should in general be okay. All right. So let's take a look at the answer, which in this case is C. But more importantly, let's take a look at why. So the explanation, percent change equals post minus pre. Okay, the 6.3 minus the 5.2 over pre, over the 5.2 times 100. In this case, 6.3 minus 5.2, or 1.1 over 5.2 times 100 is indeed 21%. In this question 2, a doctor asks you to provide serial measurements, so a series of measures of the respiratory muscle strength of a patient with a progressive acute neuromuscular disorder, such as muscular dystrophy, multiple sclerosis, or any other similar disease. Which of the following measures would you select to provide the needed information? A, forced vital capacity. B, arterial blood gas results. C, rapid shallow breathing index. Or D, maximum voluntary ventilation, or MVV. The correct answer is indeed A. Of the measures listed, only the forced vital capacity provides information primarily on the patient's respiratory muscle strength. Since the forced vital capacity includes both a maximum inspiratory and expiratory effort, it provides an overall picture of the strength of both, if you will, both sides of the equation, both of these muscle groups. Were separate information needed on either the inspiratory or expiratory muscles alone, a maximum inspiratory MIP pressure or maximum expiratory pressure could have actually been used instead. Question 3. After bedside measurement, you note that a patient's slow and forced vital capacity are approximately equal. Both are less than 60% of the predicted values. Which of the following diagnoses is least likely? Least likely. A, lung resection. B, interstitial fibrosis. C, myasthenia gravis. Or D, COPD, or chronic obstructive pulmonary disease. The answer is D, D as in David. But the explanation goes like this. If the slow vital capacity is low, a restrictive disorder is likely present, such as interstitial fibrosis, lung resection, consolidative process such as pneumonia, congestive heart failure, obesity, neuromuscular disorders such as myasthenia gravis. In these patients, the slow vital capacity and forced vital capacity will not usually differ significantly. However, if the forced vital capacity is substantially less than the slow vital capacity, air trapping is likely present, signifying an obstructive lung disease. So remember, our COPD patients have much more difficulty on the, if you will, expiratory side of the equation, particularly if they're trying to, exhale very quickly. They have, if you will, a loss of elastance in many cases. So they have this floppy, they have this very, very high compliance. So they're very floppy airways. The equal pressure point has shifted, and when they exhale, those airways like to at least partially collapse, accounting for air trapping. However, if you give them enough time to exhale, they do it more slowly. And this patient is probably hooked up to a pneumotachometer of some sort, but if they weren't, they could use pursed lips, and that would actually shift that equal pressure point kind of, closer to normal, not normal, but closer to normal, and better allow that patient to exhale fully. So in some, there would be a difference, a significant difference in many COPD patients between the slow and the forced vital capacity, with the forced vital capacity being less than the slow vital capacity. Question 4, as compared to predicted normals, a patient has a normal FEV1 percentage, a normal FEF 25-75, but a markedly reduced forced vital capacity. The test results are indeed repeatable. Which of the following is the most likely underlying problem? Choices are poor patient effort during the test procedure, B, a restrictive disorder of the lungs or chest wall, C, combined restrictive and obstructive disease, and D, peripheral or small airway obstruction. Correct answer is B, as in boy. Explanation: in the presence of normal expiratory flow parameters, such as an FEV1 percentage, FEF 2575, a reduced forced vital capacity indicates or is strongly suggestive of a restrictive disorder of the lungs and or chest wall. As for this question 5, as measured by a single breath DLCO, or diffusing capacity of the lung of carbon monoxide method, the diffusing capacity of the lungs would be decreased in which of the following cases? A, pulmonary hypertension, B, secondary polycythemia, C, strenuous exercise, and D, pulmonary emphysema. Correct answer is D. Let's look at the why, however. DLCO is low in conditions that actually impair membrane diffusion, as in pulmonary fibrosis, or decrease surface area, as in emphysema. So one of the things that differentiate emphysema from chronic bronchitis is, in fact, more emphysemics will have a more decreased diffusing capacity, or DLCO. In chronic, chronic bronchitis, the DLCO tends to be more often spared. The DLCO can also be less than normal with reduced hemoglobin, as with anemia. I think that there's fewer red blood cells for the carbon monoxide to adhere to. Decreased pulmonary capillary blood flow, such as you see with like a PE, pulmonary embolism, or decreased alveolar volume. Increases in DLCO occur with increased hemoglobin, as in secondary polycythemia, which is one of the choices in this case, increased pulmonary blood flow, increased alveolar volume, or during exercises. So you can see that in a couple of the cases, certainly B and C, they're in the wrong direction, that they would actually could enhance or increase the diffusing capacity, whereas in emphysema, it would be markedly decreased. Question 6. In reviewing a patient's chart, you note a history of COPD and a BMI, or body mass index, of 15. Which of the following tests would you recommend? A polysomnogram or polysomnography, an exercise stress test, a metabolic study, or a bronchoscopy? The answer is C. But let's look at why. The explanation: with a BMI of 15, this patient is severely malnourished. That alone is an indication for measurement of his metabolic parameters. So your basically oxygen uptake, your CO2 production, or VCO2, and your RE and REE via indirect calorimetry. Add to the COPD, in which O2 cost of breathing can be very high and excessive carbohydrates can increase ventilatory demand, as well as the need for a metabolic assessment is apparent. Other clinical situations in which indirect calorimetry studies may be indicated include severe sepsis, multiple trauma, burns, hyper or hypometabolic states, mechanical ventilation weaning difficulties, and whenever a patient's response to nutritional support is inadequate. So question 7 focuses on additional test recommendations, however, for a different patient. Which of the following tests would you recommend in order to identify the cause of dyspnea and factors limiting a patient's exercise tolerance? A, 6-minute walking distance. B, overnight oximetry assessment. C, peak expiratory flow rate, and D, comprehensive exercise testing? The answer is D, comprehensive exercise test. The rationale behind this goes like this. To identify the cause of dyspnea and factors limiting a patient's exercise tolerance, you would need to conduct a comprehensive cardiopulmonary exercise stress test. The 6-minute walk test only evaluates how well the body as a whole responds to exertion. Its use, therefore, is limited to determining overall functional capacity or changes in capacity due to therapy. Question 8 is asking you to assess airway responsiveness during a pulmonary function exam. And the query is actually coming from a pulmonologist. He wants to rule out asthma from chronic bronchitis in the patients complaining of nocturnal wheezing. Which of the following tests would you recommend? A bronchial provocation test, also known as a methacholine challenge, a cardiopulmonary stress test, nitrogen washout challenge, or thoracic gas volume? The answer is A, bronchial provocation test. More on this goes like this. Tests that are indicated to assess for the presence and the degree of airway responsiveness include bronchoprovocation studies, such as a methacholine challenge, and expired nitric oxide, or FeNO analysis. They are also indicated to screen individuals who may be at risk from environmental or occupational exposure to allergens. Question 9. Which of the following is the best test for assessing the degree of reversible bronchospasm in an asthmatic patient? The choices are A, nitrogen washout, B, spirometry before and after bronchodilation, C, maximum voluntary ventilation, or MVV, D, maximum inspiratory and expiratory force. Answer is B. And some of the explanation as to why it's B goes like this. The only test that will give you a picture of how well a bronchodilator treatment works is forced vital capacity spirometry before and after bronchodilation. An increase of at least 12 to 15%, and the books do vary with regard to this. Actually, some books go as high as 20%, but that 12 to 15 minimally as an improvement is a decent guideline. So an increase of at least 12 to 15% in the FEV1 after bronchodilator is used as the threshold to indicate reversibility. The thing I'll also say about FEV1 and FEV1 percentage, that would be the percentage of the total vital capacity that the patient can blow out in the first second of the forced vital capacity maneuver, is it tends to be less effort dependent than peak flow. So while peak flow can be convenient and it can be, kind of easy to do, the FEV1 or even the FEV1 percentage are much more reliable for these purposes. Question 10. Which of the following would provide the best bedside assessment of the need for ventilatory assistance in a patient with myasthenia gravis? A, functional residual capacity, B, vital capacity, C, closing volume, or D, total lung capacity? The answer is B, as in boy. The rationale behind this is this, that myasthenia gravis is, of course, a neuromuscular disease that affects muscle strength. And again, myasthenia gravis is one of those conditions that really starts with the face and the eyes and works its way downward and outward. Unlike Guillain-Barré, that tends to start at the extremities and work its way inward and upward. So is a neuromuscular disease that, again, affects muscle strength. Of the tests listed, the vital capacity requires the most muscular effort from the patient and would be the first of the listed tests to decrease in neuromuscular disorders. Now, things like NIF, or negative inspiratory force, would also be potentially another good choice. Except what? Except it's not a choice. Question 11 is one of those questions that relates to one of these more discrete tests of the calibration and proper functioning of the equipment, in this case, spirometers. So according to the American Thoracic Society recommendations, diagnostic spirometers should be calibrated to within which of the following tolerances? Plus or minus 1% or 10 mLs, whichever is greater. Plus or minus 3% or 50 mLs, whichever is greater. Plus or minus 5% or 100 mLs, whichever is greater. And plus or minus 10% or 500 mLs. It seems like a lot, whichever is greater. And the correct answer is, drum roll, B, plus or minus 3% or 50 mLs, whichever is greater. So simply put, the American Thoracic Society recommends for diagnostic spirometers, basically says that they are calibrated and the check should be within plus or minus 3% or 50 mLs, whichever is larger. And these sorts of tolerances that are recommended for the American Thoracic Society, these are things you just may need to memorize. If you work in this environment, maybe you don't need to memorize it, but if it's just a credential you're going for and you're not really sure if you're going to work in that sort of an environment, it's just, it's almost like when you're studying for, when you're studying for the CRT or the RRT exam, there are certain lab values you just needed to memorize. These sorts of tolerance may fall into the category of information that's potentially useful if you work in that environment. Otherwise, you're just going to have to memorize it. So this question 12 is a bit more analysis, whereas the preceding one was just a bit more just recall. Again, you're just trying to memorize or recall information. This one is a bit more, again, analysis and application. So after bronchodilator therapy, you record the following PFT data on a 67-year-old male COPD patient who reports frequent exacerbations of his condition. FEV1 to forced vital capacity of 59%. So that's the FEV1 percentage. Okay. The FEV1 is 44% predicted. You would characterize the stage of this patient's COPD as which of the following? So we're talking about degree of severity here. Mild, A. B, moderate, C, severe, and D, very severe. The answer is C, severe. So the explanation is that irreversible airflow obstruction is present when the FEV1 to forced vital capacity ratio after bronchodilator treatment is less than 70% predicted. The stage of COPD is then gauged by its impact on the predicted FEV1. If the FEV1 is less than 50%, but greater than or equal to 30%, the patient's predicted value, and there is a history of repeated exacerbation, the stage would be classified as severe. Question 13. While performing spirometry on a patient, they suddenly complain to you of severe shortness of breath and some chest pain. Which of the following actions would you recommend at this time? So what would be your next action that you'd recommend? A, call a code blue. B, call your manager. C, decrease the treadmill incline. And D, terminate the procedure, monitor the patient, notify the prescribing physician. And of course, if they lose consciousness or something drastic happens, respond to that as well. The answer is D. The explanation, patient responses that justify terminating pulmonary function testing, or you can argue any sort of diagnostic or therapeutic procedure, in close patient monitoring, including moderate to severe angina, increasing nervous system symptoms, such as ataxia, dizziness, or near syncope, near fainting, signs of poor perfusion, such as cyanosis or pallor, severe wheezing, and or dyspnea. So this speaks to a broader issue. Anything that we're doing, any procedure diagnostically or therapeutically, if the patient appears to have an adverse reaction, we stop the treatment. We of course stay with them and monitor them. If they do look cyanotic, respond to that by administering oxygen therapy, etc., and notifying both the nurse and the physician. It may be one of those cases where you're actually not necessarily calling a code blue, but you're actually maybe calling an RRT, or at a minimum, basically saying that you need some help in that room. You need, other clinical personnel, preferably a physician, but if, the nurse is right outside of the room there, get a nurse in the room to give you a hand and monitor the patient very, very carefully. Question 14. A key characteristic of all obstructive disorders is which of the following? A, decreases in lung volumes. B, increases in lung volumes. C, decreases in flow rates. And D, decrease in work of breathing. Correct answer is C. So all obstructive disorders have a decrease in flow rates. Now, in some cases, volumes or capacities may also be indicated in some cases where there's air trapping, such as an asthmatic in a severe episode, or a patient with moderate to severe emphysema, where they cannot exhale properly. So those may occur, but what universally occurs with obstructive disorders, and as part of the definition, are decreases in flow rates. A little more on the explanation. Whether inspiratory or expiratory in nature, all obstructive disorders are characterized by an impedance to flow of air. In the pulmonary function laboratory, this flow impedance always is seen as a decrease in flow as measured during the applicable phase of breathing. If the problem is mainly expiratory obstruction, expiratory time is usually prolonged beyond that of inhalation, with contraction of the upper abdominal muscles are also evident towards the end of exhalation. So with question 15, we have a patient with a history of nocturnal dyspnea, has an FEV1 of 1.5 liters before bronchodilator therapy, and an FEV1 of 1.8 15 minutes after treatment. These results indicate that the patient has which of the following? Which of the following? Has airway obstruction that is unresponsive to treatment, is suffering from a combined obstructive and restrictive disorder. C, has at least partially reversible airway obstruction. And D, is developing tolerance to a bronchodilator. So what I want you to do is, this also illustrates that there have been prior questions, answers, and explanations in this session that give you some insight. Give you some insight as to the degree of reversibility, the formula used to determine the percent change that would give you some insight as to whether or not it's at least partially reversible. So let's look at the answer. The answer, in fact, is C. has at least a partially reversible airway obstruction. But like we've done in all the other questions, let's look at the why. So the explanation relates to a percent change. So we're really going through the math here. FEV1 is greater than 20%. So 1.8 less 1.5 over 1.5. Okay, in this particular case, it's a 20%, if you will, increase in FEV1. So an increase of FEV1 of greater than, again, about 12 to 15% between pre and post bronchodilator therapy indicates the presence of at least a partially reversible airway obstruction. I ask you to kind of classify, the condition and also its responsiveness to therapy. Question 16, which of the following spirometry tests would you recommend to evaluate the severity of an obstructive lung disorder? A, forced vital capacity, B, inspiratory capacity, C, tidal volume, and D, expiratory reserve volume. The answer is A, forced vital capacity. But let's look at why. The explanation goes again like this. Because obstructive disorders limit airflow, the only measure listed that would help assess the severity of the condition would be the forced vital capacity, including its constituent points, such as the FEV1, the FEV3. Typically, an FEV1 to forced vital capacity ratio, again, of less than 70% defines an obstructive ventilatory impairment. With the exception of the residual volume and the total lung capacity, such as you'll find, which will be increased with air trapping, simple lung volumes, such as tidal volume and inspiratory capacity, are typically not useful in assessing the severity of obstructive disorders. And again, in some mild to moderate, the residual volume and the total lung capacity may not even be elevated. So it's kind of variable. But what we're going to universally see, as we've alluded to throughout this presentation with obstructive disorders, is that flows will very much be affected. And in this case, the forced vital capacity, even though it's capacity, it's really it's over time, the forced vital capacity will be affected. Which of the following diagnoses is consistent with the flow volume curve or flow volume loop that we've shown below? So take a moment, take a look at it. A, variable intrathoracic obstruction. B, fixed extrathoracic obstruction. C, small airway obstruction. And D, normal expiratory and inspiratory flow. The answer is D. To gain a little more insight, the explanation says that in a flow volume loop, the lower portion represents inhalation and the top portion depicts exhalation. In this example, there is a rapid acceleration to normal peak flow and a steady decrease in expiratory flow to a normal volume. Inspiration has a normal symmetrical shape. So on the bottom you have that normal symmetrical shape. That's the inhalation part. The top portion there, they're reaching peak flow very quickly in less than a second. And you have going out to about 4 liters, something along those lines. But you have a relatively steady decline. Just to differentiate for a moment, in the top portion, you'd have the top right portion, if there was an obstructive disorder, you would actually see kind of a carving out, that flow would wouldn't reach as high, it would be notched out, and there would be more time that it would actually take to exhale. So there would be kind of a longer longer tail to the top portion of the flow volume curve or loop. So to kind of build on what I said in the preceding slide, Okay. Which of the following choices below is consistent with the following flow volume curve? Flow volume curve. A, normal forced expiratory flow pattern. B, variable intrathoracic obstruction. C, airway or airways obstruction. And D, fixed large airway obstruction. The answer is C. And the rationale is the explanation in a flow volume loop. The lower portion represents inhalation, and the top portion depicts exhalation. In this example, there is a peak expiratory flow, and it's lower than normal. The expiratory flow is notched out and ends at a lower volume, indicating an obstructive disorder. So it's not notched out. If you compare this flow volume curve, particularly the expiratory portion, with the one in the prior question or slide, you'll see rather than having a very symmetrical decline on the right-hand portion of the top, it drops down precipitously. It kind of, it's carved out, and it's, if there's such a thing as a classic finding with a flow volume curve, this would be it. So my advice to you, if you are seeking to take the the C or RPFT exam, is get a hold of as many flow volume curves that you can, obviously comparing it to the normal one, and contrasting abnormal ones. And some of these patterns that you'll be expected to interpret will, you'll become more familiar with them. And when you encounter these in the exam, you're more likely to get the answer correct. Question 19. Which of the following would be considered key components of the forced vital capacity maneuver? A, maximal inspiration, a blast of expiration or exhalation, and a complete exhalation. B, maximal inspiration and exhalation for at least 6 seconds. C, forceful exhalation, exhalation for at least 6 seconds in adults and 3 seconds in children younger than age 10. And D, no cough in the first, second, and a fast start. So back extrapolation, less than 150 milliliters. There's a lot to this one. A lot of words. The answer happens to be A. Key components of the forced vital capacity maneuver include a blast of exhalation or expiration and a complete exhalation after maximal inhalation. So think about this. Even if you don't work in a pulmonary function testing lab, if you do bedside spirometry for let's say pre-surgical with just a bedside device, they're not going to the PFT lab. When you're doing a flow volume loop and you're doing, from which FEV1, forced vital capacity, etc., are derived, think about what you're asking the patient to do. Okay, so breathe normally, breathe normally, breathe normally. Okay. Exhale all the way. Deep inhale, inhale all the way in, and out, all the way 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 out, and then a deep hit. So you're asking them, basically what you're asking them to do in a forced vital capacity maneuver is what this question is all about. And instructing them on proper, procedure and proper technique is critically important. So what you do is before you actually have them do it, you're going to actually walk them through. This is the way this procedure works. After I put in all your data into the bedside device, I'm going to, review the instructions with you. Then I'm going to ask you to put a tight lip seal around. If they can't keep a tight lip seal, then you maybe get a flange or something that's going to actually help them do so. Generally important to also use nose clips so that you're not losing volume and flow through the nose, because basically you wouldn't be measuring, you're going to be understating the actual results, etc. And then begin the procedure. And again, you may need to do it several times. The first time they do it, they may have difficulty following those directions. And again, you want to have, a lot of these devices will actually tell you that the maneuver was, it was begun inappropriately. There was a cough. Exhalation was aborted prematurely, etc., and they'll ask you or prompt you to actually do the procedure again. But this question is all about, under classic conditions, how are you actually instructing this patient to perform the maneuver? Question 20. So we're halfway or about halfway through these questions. DLCO, so the diffusing capacity of the lung of carbon monoxide measurements, may be indicated to evaluate gas exchange abnormality in which of the following conditions? Ketoacidosis, B, myasthenia gravis, C, interstitial lung disease, and D, bronchitis. The correct answer is C, interstitial lung disease. Interstitial lung disease. The explanation looks like this. Diffusion defects are not generally seen in ketoacidosis, myasthenia gravis, or bronchitis. However, interstitial lung disease is characterized by lower volumes and a diffusion defect. DLCO is indicated to measure diffusion defect and would be indicated in this case along with measurements of volumes and capacities, which would likely also be decreased along with flow, which would often be normal or slightly increased. So what we're talking about here is a patient, so we're talking about like interstitial lung disease. So pulmonary fibrosis is one major form of interstitial lung disease. It may be, idiopathic, we didn't know the cause, or it may be some occupational exposure, or some autoimmune disorder, or another, predefined disorder. What you actually happen is you have scarring, okay, that occurs. The scarring makes the lung stiffer. Compliance therefore drops, resulting in, again, lower volumes and capacities. In some cases, that scarring will cause, if you will, a decrease in compliance. So whatever they actually are able to inhale, that lung will want to snap back to its resting condition more quickly, thereby accounting for either normal or supernormal, or higher than normal flows and volumes which are less than normal. But also what will be coupled with that is a decline or decrease in diffusing capacity. Two of the most common conditions where you see a diminishment of diffusing capacity are these forms of interstitial lung disease, such as pulmonary fibrosis, but also conditions such as emphysema. So pulmonary fibrosis, you would have actually a low compliance with, but also a low DLCO. With emphysema, you can have a low DLCO, but you can have floppy lungs. You can have very high compliance, if you will. So differentiating or helping differentiate those two conditions, under which, again, both conditions would have less DLCO, but they would differ in terms of the actual volumes and flows. Question 21. Which of the following bedside measurements require a conscious and cooperative patient? A, spontaneous respiratory rate. B, maximum expiratory pressure. C, spontaneous tidal volume. And D, maximum inspiratory pressure. Let's take a look at the answer and the explanation. Correct answer is B, as in boy. But let's look at why. Vital capacity and maximum expiratory pressure measurements require that the patient be conscious and cooperative. Assuming there is a spontaneously breathing patient present, you could measure an unconscious patient's spontaneous respiratory rate and tidal volume, as well as minute volume, and the maximum inspiratory pressure using a one-way valving system. Now, as I mentioned earlier, before we actually got into the questions, I did mention that there are some areas of the exam that RPFT and CPFT candidates tend not to do as well as other sections. And these, in general, involve calibrating the equipment, troubleshooting the equipment, as well as ruling in or ruling out what constitutes an acceptable maneuver. This question really plays to that, and there are others in this presentation to follow, which also relate to this area. So question 22. When performing spirometry on an adult patient, which of the following would indicate invalid or unacceptable test results? A, back extrapolated volume of 300 milliliters. B, time to peak flow of 100 milliseconds. C, forced expiratory time greater than 6 seconds. And D, repeat forced vital capacity match within 150 mLs or milliliters. The correct answer is A. However, we want to know more about why. So the explanation goes like this. Validity checks recommend to ensure a valid patient effort include the following. A back extrapolated volume of less than 150. Again, answer A says a back extrapolated volume of 300 ml. So clearly that exceeds the 150 mLs. 2, a time to peak expiratory flow less than 120 milliseconds. So B in this particular case is 100 milliseconds, which is, of course, less than 120 milliseconds. 3, a forced expiratory time greater than 6 seconds with the change in exhaled volume during the last 0.5 seconds of the maneuver of less than 100 mLs. So that's kind of a combined one. And 4, all repeat forced expiratory volume 6 values match within 150 milliliters. So this explanation has a lot of information in it, but hopefully it's also a cue to the folks who plan on taking the C and or RPFT exam, that if this is an area that you don't know as much about as some of the other areas, spend some time reviewing this material. And again, there's several really good reviews that are out there. Kettering is one of them. We share some of that information in at the end of this presentation in the last slide. But again, and I'll be totally frank with you, this area, when it comes to what constitutes a valid score, troubleshooting the equipment, calibrating the equipment was not a strong area for me, and I really had to spend a pretty fair amount of time studying quite hard in this area. So in contrast to the prior question, this question falls closer to the recall, or again, requires some memorization to see, kind of, for instance, between tests, how long that, what's the minimum time that you would wait, things along those lines. So I don't have any profound advice to the exam candidates, except to say, study this stuff, and unfortunately, you're going to have to memorize it, much like you have to memorize, when you're taking ACCS exam, you really have to memorize some of the more discrete lab values like BMP and procalcitonin. And that's just, you just gotta memorize those things. So this would really fall under the category, broadly speaking, of review this stuff and memorize some of these critical values. So let's take a look at this question. Following an initial open circuit multiple breath nitrogen washout technique, if another test must be performed, how long should the technologist wait before the additional test is done? And really what they're asking here is, what's the minimum amount of time? Obviously, you could wait, a greater amount of time. A, 5 minutes. B, 10 minutes. C, 15 minutes. And D, 20 minutes. The correct answer is C, 15 minutes. And so far as an explanation for this answer, it goes like this. At least one technically satisfactory test should be done. If additional washouts are performed, and they're needed, they may be needed because the test may not have been satisfactory, a waiting time period of at least 15 minutes is recommended to allow normal concentrations of, again, nitrogen to be reestablished in the lungs, the blood, and the tissues. Like the preceding question, this question does fall into the category of recall or memorization. So again, my advice is study these values, know them when you go into the exam. It is a pain in the you-know-what to memorize values, but once you have them memorized, these should be kind of easy wins for you if you put in the prep time. So question 24 asks that in healthy adults, what is the range of residual volume, or RV, to total lung capacity, or TLC ratio? The choices are A, 10 to 25%, B, 20 to 35%, C, 30 to 45%, and D, 50 to 65%. The correct answer is B, as in boy. The explanation for this particular answer is pretty straightforward. In healthy adults, the residual volume, or RV, to TLC ratio may vary from 20% in young adults to as much as 35% in older patients. And the rationale there is it has to do with as individuals age, even forget about occupational exposure, smoking, as they age, they lose about 1% of their pulmonary function for each year. This is approximate for each year beyond age 35 to 40. And that can be expressed in a lot of different ways. But if you really think about it, that the airways, just because of the natural aging process, that there'll be a certain amount of a higher amount of obstruction because of the loss of tone to the airways because of aging. So it's not an obstructive disorder per se, but it's more a function of the aging process. And in this case, it would be expressed in terms of a larger residual volume relative to total lung capacity in older adults versus younger ones. This question requires somewhat more analysis and application than what we've seen in the prior couple of questions that were really, again, much more memorization, recall in nature. So this question is asking, during a single breath nitrogen washout test, what does phase 2 include? Phase 2 include. So if you're hazy on single breath nitrogen washout test, go back and study that broadly, but also, what these different phases stand for. And this question really speaks to that. Let's take a look at our choices. A, mixed dead space gas in which the relative concentration of oxygen and nitrogen change abruptly as the anatomic dead space volume is exhaled or expired. B, an abrupt increase in the nitrogen concentration that continues until RV, or residual volume, is reached. And again, residual volume being that remains in the lungs after full exhalation. C, a plateau caused by the exhalation of alveolar gas in which relative O2, or oxygen, and nitrogen concentrations change slowly and evenly. And the last choice, D, upper airway gas from the anatomic dead space consisting of 100% oxygen. The correct answer is A. But again, the explanation will give you some additional insight. So phase one, what's going on is upper airway gas from the anatomical dead space consisting of 100% oxygen. Hence, phase two, mixed dead space gas in which the relative concentrations of oxygen and nitrogen change abruptly as the anatomic dead space, BD, A, and T, volume is expired. Phase three, a plateau caused by the exhalation of alveolar gas in which relative O2 and nitrogen concentrations change slowly and evenly. And phase four, an abrupt increase in the concentration of nitrogen that continues until residual volume is reached. So again, in this particular case, the correct answer is A. This question relates broadly to what sorts of factors can alter diffusing capacity in one direction or the other. So it would definitely benefit you to spend time reviewing that, particularly if you're planning on taking either the C or RPFT exams. So question 26. Why should a Valsalva maneuver, bearing down, a Valsalva maneuver, be avoided during a carbon monoxide diffusing capacity test using a single breath hold technique when it's being used? Let's take a look at the choices. A reduction in pulmonary capillary blood volume may produce a falsely low DLCO. B, reduction in pulmonary capillary blood flow volume may produce a falsely high DLCO. C, increase in pulmonary capillary blood volume and may produce a falsely low DLCO. And the last choice is D, as in David, increase in pulmonary capillary blood volume and may produce a falsely high DLCO. Take a minute and think about this. Again, this is a more intricate, more of analysis to kind of use some critical thinking skills when someone does a Valsalva, what's going on the physiologic level. All right, let's take a look. The correct answer is A. And the reasoning behind it is a Valsalva maneuver reduces pulmonary capillary blood volume and may produce a falsely low DLCO. So you think about what's going on. Anything that can reduce capillary blood volume means that there's fewer red blood cells for the carbon monoxide that has diffused across the alveolar capillary membrane to bind to. And because of that phenomenon, because there's less blood volume, there's going to be less red blood cells. So the end result would be a falsely low DLCO. So it kind of makes sense, but you got to kind of think it through. So this doesn't necessarily require memorization alone, but also requires kind of thinking through what actually goes on with a Valsalva, how it can affect pulmonary capillary blood volume, and what does a reduction in pulmonary capillary blood volume, how does that express? What does it actually mean? This question is really asking you to know how to label when they describe a particular, a particular test or a particular maneuver. Do you know what it is? And again, this particular one is fairly straightforward, but again, everything is easy if you know it. So you're gonna have to spend some time to make sure that you indeed do know it. So question 27, which of the following is the term used to describe the pressure developed during the first tenth of a second when the airway is blocked? A 1/10 P, a P 10%, that's B, C, a P O.1, and D, a P percentage RAW or resistance at the airway. Take a moment, look at your choices. Correct answer, drum roll, is C, a P01. The explanation or description goes like this. The output of the central respiratory centers is sometimes measured as the pressure developed during the first tenth of a second when the airway is blocked. It's known as the P100 or the P0.1. This is another question that requires the recall of discrete facts, phenomenon that happen during certain pulmonary function testing. So question 28. During an open circuit or rebreathing technique to measure ventilatory response for carbon dioxide and oxygen, what is the concentration range of oxygen? So this just means you got to go back. If you know it, great. If you're a little hazy on it, you need to go back and say what exactly is involved in conducting an open circuit or rebreathing technique to measure ventilatory response for carbon dioxide and oxygen. You just got to head back there. It's fine. It would be the sort of thing that I would have to hit the books for myself if I was I took the exam a long time ago, but if I was taking it even now. Choices are A, 12 to 20%, B, 22 to 30%, C, 32 to 40%, and D, 42 to 50%. Correct answer is A, as in Albert, as in my first name, Albert. But why? Open circuit technique. During it, the patient breathes gas mixtures containing oxygen concentrations from 12 to 20%, to which carbon dioxide is added to maintain alveolar CO2, or PaCO2, at a constant level. So again, correct answer is A, 12 to 20%. So I've always been intrigued about hypobaric conditions, not hyperbaric, not a hyperbaric chamber, but what one might experience at high altitudes. In the United States, I realize we may have folks that are listening to this presentation that maybe are not from the United States. But the United States, that might be like Tahoe, New Mexico, about 13,000 feet. There's a ski resort there, the Rocky Mountains, as much as 14, 15,000 feet. Elevation that you're going to feel. So you say, well, a lot of people never travel to the Rocky Mountains, or if they do, they're in an airplane. Interestingly enough, so jet airplane fuselages, when you're traveling, they are, if you will, pressurized to about 5,000, an altitude of about 5,000 feet. In some cases, as much as 8,000 feet. But we can kind of crudely say it would be like being in Denver, Colorado, or Mexico City. So in that 5 to 7 or 8,000 feet. So for individuals that have healthy lung function, it's not a big deal. For individuals that have compromised lung function, such as folks that have COPD or cystic fibrosis, there's a particular test that's used to emulate or simulate high altitude. Okay, and this question is really aimed in that direction. So question 29, what is the term used to describe a test designed to simulate high altitude in a subject susceptible to hypoxia and or hypoxemia when traveling to high elevations? Choices are A, high pressure simulation test, B, hypoxia inhalation test, C, decompression test, and D, hyperbaric inhalation test. Take a minute, even look at some of the labels of these answer choices. I'll be able to give you some insight. Correct answer is B, hypoxia inhalation test. Let's look at a little more on the explanation side of this. A high altitude simulation test, HAST or HAST, also known as a hypoxia inhalation test or a HIT, HIT, is used to emulate or simulate high altitude in subjects susceptible to hypoxia during air travel or when traveling to high elevations. So high elevations, again, I mentioned extremely high elevations would be anyone going to Nepal. Mount Everest, FYI, just trivia, is 29,028 feet. So that's extreme, and it's very thin air and it's also very cold air. So we don't, thankfully don't experience that. But even folks that are like traveling the foothills, like northern India, Nepal, they're not climbing Mount Everest, but they're doing some trekking there. That can be in that 18,000 feet. Definitely what would be felt by any of us with healthy lung function, even if you're young. So just something to kind of keep in mind. So when we know that folks that are COPDers or have pulmonary fibrosis or CF, it'd be very wise to test them to see if they can actually tolerate it, and if they need supplemental oxygen during the trip, that arrange appropriately for that as well. So this question is geared towards cardiopulmonary exercise stress testing, or also known as exercise stress testing. Okay. And it's asking, in exercise stress testing, when does anaerobic threshold occur? So, what's actually happening physiologically? There's certain things that actually can be measured as well. So let's take a look. Our choices. A, when energy demands of resting muscles exceed the body's ability to produce energy by aerobic metabolism. B, when energy demands of exercising muscles exceed the body's ability to produce energy by aerobic metabolism. C, when energy demands of the exercising muscles exceed the body's ability to produce energy levels by anaerobic metabolism, anaerobic, without oxygen. And D, when energy demands of the resting muscles exceed the body's ability to produce energy by anaerobic metabolism. So a little test-taking strategy here. We're talking about exercise stress testing. Exercise stress testing. So even if you're kind of a little hazy, you sit for the exam, you studied, you knew it, and somehow it just popped out of your head. Think about what exercise stress testing. So two of these answers talk about resting muscles, resting muscles. That's A and D. If it's exercise stress testing, it's probably not that. It probably involves exercising muscles, exercising muscles. So even if you're kind of hazy on the nuance of answering these questions, you can at least, help yourself by, increasing your chances to, instead of a 1 in 4 to a 1 in 2 or a 50% chance of getting the right answer. So let's take a closer look here. Correct answer is B as in boy. So it's, the energy demands exceeding the muscles ability to produce energy by aerobic. Then you go into an anaerobic metabolism. And the explanation is going to give you the more, the more detailed explanation. It goes like this: measurement of and the analysis of exhaled gas during exercise allows non-invasive estimate of the aerobic anaerobic threshold, the anaerobic threshold, AT. This threshold is also termed ventilatory threshold when it is denoted by a change in ventilation and CO2 production. So if you were to put this on a graphic, and they could do this to you, you'll see you'll see like an inflection point where it goes up, gets steeper very abruptly. The AT, or anaerobic threshold, occurs when the energy demands of exercising muscles exceed the body's ability to produce energy by aerobic metabolism. Aerobic metabolism. Sort of makes sense. This question is really aimed at normal oxygen consumption levels and knowing, how is that actually expressed in a healthy adult. So the question specifically is, what is the normal oxygen consumption level in a healthy adult? Choices: 35 milliliters of oxygen per minute per kilogram. So you also need to know the kind of the labels that go on the number. B, 0.35 milliliters, oxygen per minute per kilogram. C, 25 liters per minute, STPD. And D, as in David, 0.25 liters per minute, STPD. Giving you a second to think this one through. Maybe get it out of your memory banks. Correct answer is D as in David. D as in David. And the explanation is straightforward. Healthy patients at rest have an oxygen uptake of approximately 0.25 liters per minute, STPD, or approximately 3.5 mLs of oxygen per minute per kilogram, also known as 1 met. So the 1 met is really, think of it like a benchmark for, what's normally, a way of normally expressing normal oxygen uptake. So it's a benchmark against which, when you start putting a load on the patient to kind of see, how it actually changes, how it should change normally, and what happens if it changes at an abnormal rate. So it's fairly reasonable to expect that there'll be, I'd say, a few questions related to the 6-minute walk test that are on the C and RPFT. It doesn't replace exercise stress testing. It doesn't replace the pulmonary function testing, but it can be very valuable to augment them and think of it like a montage. We're not diagnosing patients based on one value. We're looking at a lot of different things. We're obviously physically assessing the patient. We're looking at the patient, so we're helping with a diagnosis, or at least a differential diagnosis to limit the number of conditions that we believe the patient has by looking at a lot of different things. And the 6-minute walk test can be helpful, just in general, but also as it relates to, in the montage of pulmonary function testing and exercise stress testing. So question 32. You are performing a 6-minute walk test on a 71-year-old male patient. The patient pauses to rest. How is the time to be noted? A, the time should be paused as the patient rests and then resume when he starts. B, the time rested is added to the end of the 6 minutes and he will be asked to keep walking. C, the timer, the person timing, continues to run during any pause during the test. And D, pauses are not allowed, and the patient test will need to be performed later on. Okay, so you're thinking about, this is something. If you know it now, great. If you don't, once you memorize it or you study it, you should be fine with it. The correct answer is C. So it's just a continuous timing. The patient is absolutely allowed to sit down. They need supplemental oxygen. They're provided with supplemental oxygen, etc. And when they feel up to it, they stand back up. And it's the total amount of distance that's walked during the 6 minutes, including, again, while they're resting, they're not going to be making any distance at all, but they're allowed to get back up and continue walking. And the explanation just goes on that. The objective of the test is to have the patient walk as far as possible in 6 minutes. The patient should be encouraged throughout the test, and it is recommended that the standard phrases be used: reduce inter-tester, or test-to-test variability. It should be emphasized that the timer continues to run during any pause in the test. And really what they mean is pause in the patient's walking during the test. This question relates to a methacholine challenge. And remember that methacholine is a cholinergic, not anticholinergic. It's a cholinergic substance that can well induce bronchospasm. Okay, so it needs to be done in very controlled circumstances. There needs to be a rescue protocol. If you think about it, if you're trying to induce a bronchospasm, you need to make sure that you have, adrenergic bronchodilators, you have oxygen, you have access to, emergency staff, emergency equipment, things along those lines. So it definitely would behoove you to understand and study, if you need to, the methacholine challenge. So question 33 relates to that test. Which of the following is the term used to describe methacholine concentration at which there is a 20% decrease in FEV1 in the bronchial provocation testing? So it's methacholine challenge is also known as a bronchial provocation test. Let's look at the choices. A, FEV 20%. B, PC 20. C, MC 20. And D, FEV 1-20. Correct answer is B, as in boy. And the explanation says that spirometry and sometimes, again, SGAW are measured after each dose. So most clinicians consider the test result positive when inhalation of methacholine precipitates a 20% decrease in FEV1. The methacholine concentration at which this 20% decrease occurs is called the provocation concentration 20, or PC20. So it's actually a bit intuitive. If you think about, if you know that the methacholine challenge is also known as a provocation, bronchial provocation, that's probably helpful in remembering this as well. If the accumulative dose is measured, it would be basically the provocation dose, or PD20. PD20. So just distinguishing between PC20 and PD20, both are kind of key terms in understanding the bronchial provocation testing, or again, also known as methacholine challenge. So this question is kind of asking, this is a bit of an analysis question. They're kind of asking you, well, what's actually going on? Why might a patient have a decreased, maximum inspiratory pressure? And in this case, if they have emphysema. So what is the most likely cause of a decreased MIP in a patient with emphysema? It's really not just asking you about PFTs, but also understanding a bit more about what's going on physiologically with a patient that has emphysema in relation to the MIP test. Choices are post-polio syndrome, B, hyperinflation, C, kyphoscoliosis, and D, phrenic nerve damage. This one really looks like the choices, again, everything is obvious if you know it, but if you think about, well, is there anything in this, in the question to say the patient had polio? Is there anything that says they have, kyphosis, scoliosis, kyphoscoliosis? Was there any trauma going on causing phrenic nerve damage? So the distractors are just that, okay? And you also kind of know that with emphysemic patients, particularly if they have moderate to severe emphysema, that they tend to have hyperinflation because they air trap, they have difficulty exhaling. A lot of these obstructive disorders, it's more on the exhalation side of the equation. So I kind of took you right down the pathway to the correct answer, B, and it just goes on to say that the MIP may also be decreased in patients with hyperinflation, such as emphysema, where the diaphragm is flattened and increased volume of trapped gas in the lungs is really causing a lot of that. This question is framed around kind of understanding a little bit of the rationale or the indications for doing preoperative pulmonary function testing. So it's asking, why is preoperative pulmonary function testing performed? Choices: A, as part of the insurance pre-approval process. B, to evaluate a patient's risk of developing chronic lung disease prior to surgery. C, to rule out existing pneumonia. D, to evaluate surgical candidates at risk for developing respiratory complications. The correct answer is D, as in David. And this one, again, if you look at the distractors, if you will, and really kind of read them carefully, patient has pneumonia. There's going to be other signs and symptoms that they have that. Chronic lung disease before surgery. I mean, it sounds vaguely correct, but it's not. It's by far not the best answer. And then A, as a part of the insurance pre-approval process, rarely is it. Rarely would it be anything like that. So the best answer by far is to evaluate surgical candidates at risk. They're basically, they may be actually too diminished. So the pre-pulmonary function testing may be so poor that they're ruled out. They're ruled out for the procedure. So by way of an explanation, preoperative pulmonary function testing is one of the means available to clinicians, to the clinical team, to evaluate surgical candidates at risk for developing respiratory complications. They're also used to risk adjust for comparing outcomes amongst various service providers. Here again is one of those questions that really talk to, determining the proper functioning of equipment, in particular the precision and the accuracy of equipment. So, question 36. What is the term used to describe any known signal, any known benchmark for an instrument that can be used to determine its accuracy and precision regarding PFT equipment? Choices are A, calibration, B, standard, C, correction factor, and D, control. D, control. Correct answer is in fact D. Let's look at why. A control is any known test signal or known value for an instrument that can be used to determine its accuracy and precision. So it's a known value, and deviations from that, when you actually, when you actually run the test using the control, deviations from that, there's a certain tolerance that's allowed, but extreme deviations would basically indicate that the precision and the accuracy are not within alignment, and that the validity of the tests that are produced using that equipment would be in question, would actually be invalid. Here again, this question relates to, in this case, calibration. So maintaining and helping ensure the accuracy and precision of equipment. And this question is asking, what is the most common technique for analyzer calibration? A, single point calibration. B, 2-point calibration. C, multiple point calibration. And D, control point calibration. Take a moment, think this through. The correct answer is B, as in boy, 2-point calibration. You even think about, you shouldn't be thrown off by, like for instance, what we do with oxygen analyzers and what we may do with blood gas analyzers. But you think about, particularly oxygen analyzers, we typically do a 2-point calibration. So that actually, not because something sounds correct, it's always correct, but in this case, it's consistent with calibrating other equipment that we work with routinely. So the explanation is that the most common technique for analyzer calibration, 2-point calibration, involves introducing 2 known gases. And 2 known gases also at known concentrations or percentages. This question is a little bit involved. The question is fairly straightforward. It's the answer choices in the explanation. Okay. So the question again is, how is the lower limit of normal established in pulmonary function testing or tests? A, by analyzing a measure in a subject when they are healthy and comparing it to that measurement when they are sick or unhealthy. B, by analyzing a healthy family measure of the subject and determining the variability of that measurement. C, by analyzing a measure in 6 subjects and determining the variability of that measurement. And D, by analyzing a measure in healthy subjects and determining the variability of that measurement. Take a moment, give it some thought. There's a fair amount to this particular question. Correct answer is D as in David. D as in David. The explanation is a bit involved. Determining the lower limit of normal, LLN, should be done by analyzing some measure, forced vital capacity, FEV1, in healthy subjects and determining the variability of that measurement in that healthy subject population. In clinical medicine, the 5th percentile is often defined as the lower limit of normal because it represents the segment of healthy subjects farthest below the average. Even though subjects in the 5th percentile are healthy, they are arbitrarily defined as abnormal for clinical purposes. So this is something that it sounds a bit like doublespeak. I don't know what to tell you except you probably will have a few questions on the exam that relate to lower limit of normal, and it would behoove you to just have a working idea of what is meant by it so that they actually give you it in a particular scenario in a question that you're familiar with it enough so that you can increase your chances of getting the correct answer. Lower limit of normal. This is more like a case scenario. So in this particular case or question, they're asking which of the following FEV1 percentage prediction indicates moderately severe obstruction. Greater than 70%. B, 60 to 69%. C, 50 to 59%. And D, 35 to 49%. Again, remember that the FEV1 percentage, the FEV1 percentage is the amount of gas that's actually blown out in the first second of a forced vital capacity maneuver. Correct answer is C, 50 to 59%. 50 to 59%. And let's look at why. Explanation. So grading severity of pulmonary function testing parameters be a good idea, again, whether you use Kettering, whether you go back to Ruppel's textbook, excellent. That's all about pulmonary function testing. You're going to see that they actually talk about this. And you'll see that a moderately severe obstruction, it's really the 4th line down, is 50 to 59%. So spend a little bit of time, I say, memorizing, refamiliarizing yourself, whatever the case be, with grading the severity of pulmonary function testing parameters. So this is the last question that we're going to go over during this particular, about 2-hour session here. And this one also relates to kind of knowing, what the normal values are, but also when they're diminished, what those, the degree of severity, and what sort of percentage, normal or predicted, would somebody be off, in order to categorize them as moderate, moderately severe, et cetera, et cetera. So this question, according to the American Thoracic Society and the European Respiratory Society Task Force, which of the following suggest moderate severity based on FEV1? FEV1 less than 35% predicted, FEV1 equal to 35 to 49% predicted, FEV1 50 to 59% predicted, and D, FEV1 60 to 69% predicted. So again, if you're kind of paying attention to the prior question, it should look a bit familiar. It's not the same question, but it certainly, it relates to it and relates to that table. So the correct answer is D, And let's look at why. The explanation again relates back to the table there, and it is really saying if you just kind of follow what you have here, moderate, again, moderate severity. Moderate severity is that 60 to 69%. That's the third line that's actually down in this. So it's, moderate severity. The prior one was moderately severe, moderately severe. So read your questions very carefully. Try not to let your eyes kind of skip over and, make a silly mistake. So now that we've kind of worked through a number of questions, we went over initially, some of the resources that are available from the MBRC, some of the general points of kind of how to identify the weaker areas by looking at the exam matrix and spending, a disproportionately larger time on the areas you're less familiar with and less time on the areas that you're more familiar with. Okay. Now let's talk about actually the other kinds of preparation, the things that you can do to prepare your mind and your body and your soul. I don't want to sound really cosmic here, but I've been teaching a long time. I've been teaching almost 30 years, mainly respiratory care, but I teach healthcare management as well. And what I tell folks before taking an exam, a credentialing exam, my respiratory students will be taking their exam in about 2 months, 2.5 months, is this doesn't define your life. We want you all to pass the exam. If you put enough time in, even if you have to take it more than once, you'll pass. Okay, and I mean that. The vast majority of the students that I talk, it's not about me, but it's about, we have a really good bunch of students. We screen them very carefully. We have quality programs, and we have quality students, and we're pretty well supported as well. So exam candidates in preparing their body, mind, soul, what they can do, pace themselves, preparing, minimum 1 to 2 months in advance, unless you do this stuff all the time and a cold. Encourage your peers to start a study group with you. Become familiar with the exam matrix, as we talked about earlier. Get your hands on, legitimately, get your hands on as many practice exams and questions as you can, okay? Get enough rest in advance. You'll be nervous, but again, the test that you take, the credentialing exam, does not define your life. And if you put enough time into it, you'll be fine. And I mean that. I'm not just saying it to say it, but it's just a matter of take a little bit of pressure on yourself taking the exam. Again, I shared with you earlier that the ACCS exam was the first computer-based credentialing exam I had taken, because I've taken all my other exams a long time ago. And I was nervous and stuff, but I said to myself, you know what? If I don't pass this, I studied for it. I didn't go crazy studying for it, but I did. I said, I'm going to take this again. It's not going to be like it was a never event. I'm not going to tell anybody. I'm not going to brag about the fact that I failed it, but I'm going to take it again, and I'm going to pass the damn thing. So just kind of, don't be your own worst enemy. I would say just try to spend some time, appropriate time studying, but also preparing your body, mind, and your soul to do well as well. The preceding slide was more or less what to do to prepare yourself. And this slide is maybe what not to do. Don't underestimate the exam. I'm not trying to psych anybody out, but the RPFT, it was really a long time ago I took the CPFT, but the RPFT was probably the most difficult credentialing exam that I took. I'm just, with me, the calibration stuff, the drift, the troubleshooting, it's not an environment that I've worked in. Even then, but since then, not an environment that I've really worked in. So it was just like I really had to spend a lot of time studying, those sorts of things. In fact, some of the things that we had covered in the questions that we've used in this particular review presentation. Don't get overly nervous. It doesn't define your life. Just, you're going to be a little bit nervous. Use that to channel your study habits. Say, I'm nervous. I don't want to fail this exam. Use that as a motivator, positive motivator. Don't place too much pressure on yourself. And I'm saying this partying the night before, but just focus. You get enough sleep, just get enough sleep, things along those lines. And when I say you should be fine, if you take that, you like anything, you map out a plan, you got a good plan, you work the plan, you execute the plan. You don't take shortcuts on it, you execute the plan, and you actually should be fine. As the exam nears, day or 2 or maybe 3 before the exam, know the location. I indeed took a test run. The test center was 2 towns over from me. It wasn't very far, but I, just didn't want to be that guy who's like going, blaming my MapQuest or whatever I used because I went down a wrong way, one-way street the wrong way or something like that. So I just like made sure I knew where it was, took a test run, and I was like, okay, I kind of know where this is. I was mindful of traffic times and things along those lines. Underestimate the exam parameters, know the number of questions, the time allotted. I think I mentioned this earlier in this presentation that when I went to the MBRC website, there's, they actually had a simulated screen of what you're going to see, but it also, told you how to save questions so you can go back to them and things along those lines. Now, to some of you youngsters who've taken all computerized exams for your, credentialing exams from the MBRC, you may know how to do that. But again, if you haven't, or if it's been a long time since you've taken your credentialing exam, computer or not, really behooves you to say, this is what the screen's going to look like. P.S. is on a little bit of a lighter note. My wife and I fish a lot, and I wore this orange fishing shirt. It's really designed to keep the sun off of your skin. And the problem is that the screen actually has a picture of you the entire time. So I had to look at my orange shirt it was 160 questions because 140 count and the 20 are experimental questions that don't. So I had to look at this orange shirt the entire time I was taking this exam. So this is sort of a silly sidebar. Just don't wear a shirt that kind of annoys you a little bit like my shirt did when I took it. Review the MBRC website, as I said, for the mechanical issues. Ensure that you have proper identification. Don't rely on unreliable people, maybe even for transportation to get there. When you get there, they're going to say to you, I know I'm not as much a phone addict as some people, is to take your phone, and they're not going to allow you to have your phone in the testing center, not the center, but where you actually sit, where the modules are, the computers are. You can't bring your phone in there. So what I did was they have lockers. I just brought mine in my car, locked it in my car, called it a day. There's some other, rules along those lines. But if you're a phone addict, get it out of your system. When you sit for the exam, it is what it is. Be focused on the exam. Regarding test taking strategies, as I was going through some of these questions, I tried to impart, I tried to exemplify some of these test taking strategies, how to like eliminate, I'm going to say obvious, but more obvious wrong choices so you can, if you don't know the exact right answer, you can at least increase your chances of getting it. Multiple choice exam. So the right answer is there. So it's not like one of these fill-ins where you got to like memorize a different level of if you will, memorization or recall when the correct answer is there. So keep that in mind. Don't get psyched out. The first few questions are hard. Sometimes they actually do that. I don't know why they do it. Maybe to psych out exam candidates. But if they throw the first, 2 out of the first 4 questions are crazy questions, don't think the whole exam is going to be like that. Don't change your answer unless you misread the question and or the answer, or you've identified that you did the math wrong and it's an obvious mistake. You didn't move the decimal point, something along those lines. So yeah, if you find something like that, an obvious mistake, fix it and change your answer. If you're kind of guessing or taking an educated guess, more times than not, 65% of the time, your first instinct, will be correct. You actually have knowledge that's stored in kind of your subconscious, which will work, to your betterment if you just don't kind of overthink it. And don't spend too much time on any one question. Pace yourself. You can mark the question to come back to it. It's not like the old days where if you didn't, with the answer key, if you didn't skip a spot where you skipped a question, you could screw up your entire exam. This isn't really like that, but there's a way that you can actually, demarcate it and say, I got to come back to this, and you'll come back to maybe the 5 questions that you didn't answer the first time around. But that way you can keep a good pace. A little more on test taking strategies. If you don't know the right answer, try to identify the wrong ones or the outliers. We did a little bit of that when we went over the 40 questions in this presentation. Eliminate, turn a 25% chance of the right answer into a 33 or a 50% chance. If you don't know, generally the first inclination, as I said earlier, is correct. The corollary goes like this. If you don't know the answer but have a hunch, go with that choice. Often the first hunch is correct, providing you don't kind of overthink it and mull over it and obsess over it. I at times tend to overthink. I'm a very analytical person. I overthink things sometimes. My wife reminds me of that. I remind myself at my old age of that as well. but just something to kind of keep in mind. If you don't know the information in a question, normal electrolyte, blah, 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 focused on what you do know. Many times, just like in a clinical setting, you often, don't have all the information, but you can make recommendations based on, if you know a lot of it, you can make recommendations. In this case, you can, increase your chances of a correct answer by focusing on what you do know, So by way of some take-home messages, knowledge is empowerment. It doesn't mean you're better than other people, but it means that, again, you can contribute to helping make a diagnosis with a patient, and then obviously contribute to that treatment plan if we can get a correct diagnosis. It also is good for our profession. It's good for you. It's good for your department if you have answers and you can show the team, the nurses, the doctors, the physician assistants, the nurse practitioners, etc., that you can actively contribute. And one of the ways you can do that is by having knowledge in these various areas, in pulmonary function testing, in critical care, in peds neonatal specialties, things along those lines, mechanical ventilation, patient management, things along those lines. So knowledge is empowerment. Education and credentials are pathways to knowledge. The C and RPFT are two such credentials which can empower you, open up doors, even if it's down the road you may not want to work. If you work in acute care, you may not want to work in acute care in 5 or 10 years. And pulmonary function testing environment may be a more predictable environment, maybe less physically demanding than running around the hospital, dragging ventilators around, things along those lines. So something to think about. However, these are tough exams that require a strategy to do well and hard work to actually execute the strategy. Simply put, becoming proficient at performing and interpreting pulmonary function tests takes time and effort. There are many resources available, and those seeking these credentials should absolutely use them. So on a closing note, I want to share some selected resources with you. Carl Motran's Rupels of the Manual of Pulmonary Function Testing. The 12th edition came out fairly recently. It is an outstanding book. It goes, so if you really want to know all the ins and the outs, Rupel by Carl Motran would be the textbook you want to get. MBRC, I had some, URLs early in this presentation, to the exam matrix, to their website, etc. Spent some time there. And then I included the, Egan's Fundamentals of Respiratory Care has a chapter done by one of my colleagues in pulmonary function testing, Dr. Zaza Cohen, as does one of my other textbooks, Clinical Assessment and Respiratory Care. And then I put in, the Kettering.org. I'm pro Kettering. I've used Kettering material to study for various things. I've recommended my students to it as well. And there's a host of other potential sources that are out there as well. I would encourage you, probably don't go to 20 different sources, but again, there's certain ones that are out there that are pretty darn reliable. There's even, believe it or not, some reliable like YouTube videos. You have some of your more prominent, Ohio State and the Cleveland Clinic, University of California at San Diego have some tutorials as well. So spend some time, reviewing that stuff as well. But don't rely on them alone. Rely on these reliable sources that we have here that are tried and true. So with that, I want to thank you for enduring this almost 2-hour presentation. Hopefully you've derived a fair amount out of it. If you've enjoyed it and you feel like you've gotten a lot out of it, please pass the goodwill along. And then, again, what we'll probably do is we'll have other, if you will, CEU sessions and presentations in the area of pulmonary function testing. We're increasing our ensemble and pulmonary function testing CEUs and in other areas as well. So we encourage you to visit A&T lectures for all of your CEU needs. And we want to, again, thank you for the exam takers. Wish you the best of luck in passing the exam. Thanks a lot and have an absolutely wonderful day. Bye.